In today's online surgery clinics, we shall be looking at examination of varicose veins. Last week, I went through, gave a short lecture on varicose veins, and today we go into details of how you examine a patient with varicose veins, which are very important for the exam. Okay, in order to understand the various tests that you're going to do on these varicose vein patients, it is very important to understand the basic anatomy and the blood flow in the lower limbs. Okay, in both the lower limbs. Okay, this is a picture showing you the outline of the various veins. There are two sets of veins, the deep system and the blue one is your superficial system. Okay, you've got your deep and your superficial system. The deep system consists of the femoral vein here, higher up in the thigh, the popliteal vein around the knee, and the tibial vein below the knee, the anterior and posterior tibial veins. Whereas the superficial veins consist of two sets, the long saphenous and the short saphenous veins. Long saphenous throughout the leg from foot right until the femoral junction here, and the superficial or the short saphenous veins is from the foot right until the popliteal vein at the back of the knee joint. Now, the flow of blood is from the deep veins, from the superficial veins into the deep veins. Okay, and this flow occurs at the various levels in the leg as well as the thigh and at the popliteal and femoral junctions. The deep veins in the thigh, which connect the superficial to the deep veins, are known as the deep perforator veins or communicating veins, which communicate the superficial veins to the deep veins. So the blood flow is always from the superficial system to the deep system through these communicating deep perforators, and at the two junctions, the short saphenofemoral femoral junction here, the saphenofemoral junction and the saphenopopliteal junctions. This picture again shows you the saphenofemoral junction here in the groin area, where the long saphenous veins empties its blood into the deep vein, the femoral vein. And then these are drained. There are 4 or 5 communicating veins that drain the upper part of the thigh into the saphenous vein, which then goes into the femoral vein. So in high ligation, these communicating veins, these branches, must be all ligated and cut off. Then you have the saphenopopliteal vein here, junction here, which is at the back of the knee, where the short saphenous vein empties into the popliteal vein in the knee. And so these are the two sites, the saphenofemoral junction and the saphenopopliteal junction. So the flow of blood is always from the superficial to the deep in normal individuals. And these are assisted by the calf pump, the deep perforators, which drain the blood from the superficial to the deep system, and valves, which keep the blood flowing upwards from the foot to the center. And this is the unidirectional. The blood is always unidirectional. In varicose veins, this direction of flow may become reverse because of the valve problem, incompetence of the valve, and also incompetence of the deep perforators. This picture again shows you this is a normal venous drainage of a lower limb. You have your deep system, okay, and the superficial saphenous system, which drains into the saphenofemoral junction and the saphenopopliteal junction in the calf. And there are communicating deep veins called deep perforators from the superficial to the deep system. This is the normal drainage. Here it shows you the saphenofemoral junction here. Okay, and in this patient, the long saphenous vein drains the blood into the femoral vein. Then you have got the deep perforators. The A here is the deep perforators, which are also incompetent. So In saphenofemoral incompetence, there's blood flow backwards from the femoral back into the saphenous vein. And in the leg, from the deep veins of the leg into the long saphenous and short saphenous veins. As a result of this backflow, the superficial veins becomes dilated, tortuous, and elongated. And these are the varicose veins. And in these patients, there is venous hypertension. There's increased pressure in the venous system in the leg because of this stasis of blood. Come to examination proper of a patient with varicose veins. First, you have to introduce yourself to the patient and gain the patient's confidence. And then, to introduce yourself to the patient, wash your hands, briefly explain to the patient what the examination involves, how the examination, how do you carry out the examinations, and that does not involve pain or discomfort. Ask the patient to remove their bottom clothing, exposing the entire lower limbs, and offer a chaperone to the patient if needed. So you start the examination by inspecting the patient. And while you carry out the stages of the investigation examination, you must be prepared to be instructed to move on quickly to certain sections of the examination as requested by the examiner. Okay, next we come, once you have settled with the patient, you're quite comfortable and she is very comfortable with you, you go to the history taking. There are a lot of symptoms that a patient may present with varicose veins, and this is a long list of symptoms that I've put here. But the most important symptoms are prominent veins which are dilated and tortuous over the leg and thigh, aching of the legs, especially legs and calf, and which becomes worse at the end of the day after prolonged standing, and swelling of the leg. And the relieving factor is usually elevation of the leg. The swelling and pain becomes relief with elevation of the leg. Then you can have skin changes, discoloration, hyperpigmentation, and thickening of the skin, and eczematous type of lesion, hardening of the skin, and that is due to lipodermatosclerosis. Then the patient can have ulcers, which are usually chronic, non-healing, and recurrent. Bleeding due to minor trauma, because these engorged veins are very superficially located, and minor trauma can lead to profuse bleeding. And pain is a very important symptom, which usually indicates infection and thrombophlebitis or even DVT. So pain in varicose veins is not a very good sign. Next, we come to examination of the limb. Okay, and as usual, it consists of the inspection, palpation, and special tests. The inspection involves the location of this location of these dilated veins. Where are they located in the thigh and the leg? And then how big are these dilated veins? What are the color of these dilated veins? Okay, and then palpation to look for the various minor tests that I will describe later. So look for all those things, and also palpate for tenderness or any defects or gaps along the line of the vein. Okay, so these are very important. Next, you have some special tests, among which the three important ones are the Trendelenburg test, the tourniquet test, and the Berthes test. Besides that, there can be a lot of signs as given in this chart here. Okay, superficial thrombophlebitis with tenderness, ankle flare, the flaring redness around the ankle. You may notice spider veins, especially in the thighs and leg, reticular veins, Safina varix, and then the others are not so common. So these are the various signs that you look for in this. Inspection of the legs for varicose veins involve two main aspects. You consider two main aspects. First, looking for signs associated with chronic venous insufficiency. Okay, the VCVI. Okay, and these include varicose veins, varicose eczema, hemosiderin staining, which present as brown patches. Ulceration, commonly located the lower third of the leg, the medial aspects, especially around the ankle. Dermatosclerosis, which leads to hardening of the skin, swelling of the legs and the calf, scars indicating previous surgery on the limb, and also looking for obvious varicosities which may be present in the lower limbs, and inspecting the cause of both the lower long and short saphenous veins. The second group of findings that you would look for in inspection is signs associated with arterial disease. This is very important because treating of varicose veins to a certain extent is determined by the arterial status of the ischemic status of the limb. Okay, so whether it is suitable for compression therapy depends on whether there's a patient has got significant arterial disease at the same time. And signs of arterial disease involve loss of hair, shiny skin, tapering toes, nail thickening and friable, ulceration, especially over pressure points, and decrease or absence of peripheral pulses. These features are known as trophic signs, and these are signs of chronic ischemia of the lower limb. Okay, this the special test which I was mentioning. There are three types of tests. One is known as the saphenofemoral test for the saphenofemoral incompetence. The other is the second one is the test for perforator incompetence in the lower leg, deep perforators of the lower leg, and also test for the deep vein thrombosis, the patency of the deep veins. Saphenofemoral the competence and the test done is mainly the Trendelenburg 1 test. Then you have your minor test known as the Morrissey-Scoff impulse test. For deep perforators in the leg, the incompetence can be tested with Trendelenburg 2 test. Okay, and then you have your tourniquet test. Minor test will be your Pratt's test and Fagan's test. And test for deep vein thrombosis, the main test is known as the Perthes test or the modified Perthes test. Minor tests include the Homan sign and Moses sign. Okay, this picture here shows you the long saphenous vein from the foot to the femoral artery and joins at the saphenofemoral junction here. Okay, and then it gives off multiple tributaries along the thigh and leg. The short saphenous vein or the small saphenous vein along from the foot right up to the knees, and it empties into the popliteal vein at the back of the knee joint. Okay, now this chart here shows you the flow of the blood, and then how the occlusion of this SF junction will help you diagnose the condition. Okay, so this is the deep vein. Okay, deep vein here. Then this is your superficial vein, which consists of the long saphenous and the short saphenous vein. The short saphenous vein empties into the popliteal vein at the knee joint, posterior part of the knee joint. And then the long saphenous vein empties into the femoral artery, femoral vein at the SF junction in the groin. Okay, then the deep perforators or the DP here, these are the veins that drain the blood from the superficial into the deep veins, this way, one way direction. And the direction of flow is from the foot right to the center. And this is the direction of flow. So now occluding, and the flow is from superficial to the deep in normal individuals. Whereas if these veins are incompetent, these valves are incompetent, then there can be a backflow from the deep into the superficial system. And the test that we do will detect the site of this incompetence. Okay, for example, occlusion of the SF junction and asking the patient to stand, the blood does not drain back into the saphenous system here, long saphenous system or the short saphenous system. Therefore, the veins are not seen. So when you release the pressure, if the veins fill up rapidly from above, then you know it is SF junction incompetent. If on the other hand, if the veins fill up slowly from rapidly from below coming upwards, then you know the deep perforators are incompetent. So always must remember, flow is from superficial to deep. If there's significant flow from the deep to the superficial, that means there is incompetence at the SF junction, SP junction, or the deep perforators. Okay, this slide shows you just summarizes the Trendelenburg test and the tourniquet test. So in the Trendelenburg sign test, the patient is asked to lie down, the leg is elevated, and the engorged veins are all emptied by pressure and drain off the blood into the deep system. And then you apply pressure on the SF junction. The SF junction is located by locating the femoral artery pulse. The saphenofemoral junction is medial and 2 cm below the femoral artery. So once you have located and applied pressure with your fingers at the SF junction, then ask the patient to stand up and watch for varicose veins. If the varicose veins are controlled, that means the veins do not become prominent, then the SF junction is incompetent. Okay, by pressing on it, it controls the prominence of the veins. Therefore, it indicates that the SF junction is incompetent. If not, there is an incompetent perforator below it. Okay, if it fills up from below, that means one of the perforators are below incompetent and it fills up from below. So Trendelenburg 1 sign is to check on the SF junction incompetence, whereas the Trendelenburg 2 sign is an indicator of deep perforator incompetence. Okay, now coming to tourniquet test, same principle. Patient is made to lie down and the leg elevated and the veins are emptied of blood. Patient supine with the leg elevated to empty the engorged veins. Apply the tourniquet to the thigh, upper thigh here. And sometimes if you treat tourniquet test, you may want to apply another one here, another one here. Okay. Then you ask the patient to stand. If the varicose veins are controlled, incompetence is confirmed, is above the tourniquet. That is your SF junction. If the varicose veins are not controlled, then the bleeding, the filling is from below, and that indicates deep perforators incompetence. Okay, and this test can be repeated with the tourniquet placed at 3 sides, 1 above and 2 below the knee, and this is known as the 3 tourniquet test. So with this, you should be able to detect where is the site, exact site of these perforators, which you may have to subject to treatment. Okay. This is the pictures to demonstrate the Trendelenburg and the tourniquet test. The Brody Trendelenburg or the Brody Trendelenburg test, patient lying flat, legs elevated, all the veins are empty of their contents here. Okay, so no more engorged veins. Then you occlude the patient's groin, the SF junction, saphenofemoral junction, which is medial to the femoral arterial pulse, medial and 2 centimeters below. Okay, here. And then you ask the patient to stand. So when the patient stands up, if it is controlled, that means there's no backflow, there's no prominence of veins, that means the incompetent is at the SF junction. Then when you release the pressure at the SF junction, then the blood fills rapidly from above. So this clearly indicates is your incompetence at the SF junction. The tourniquet other side, the other end is your apply a tourniquet above the upper part of the thigh. Okay, after emptying the blood from the lower limb, apply a tourniquet. Then ask the patient to stand. With the tourniquet on, if the veins fill from below, that means the Deep perforators in the leg are incompetent, which are usually present below the lower third of the thigh and the upper and lower end of the leg. Okay, this is a summary of the Trendelenburg tourniquet test. Again, Trendelenburg is to test for SF incompetence. Patient supine with the legs drained, occlude the SF junction and stand. Ask the patient to stand. If the varicose veins refill rapidly, that means within 30 seconds from below, the fault is below. That means below the SF junction. If there's no rapid filling with the SF occlusion, then the SF junction is incompetent. The tourniquet test is a test also similar, but it's also for as not only for SF incompetence, but it's also more for the perforators, especially the 3 tourniquet test. Supine with the veins drained, tourniquet around the upper thigh, and the patient to stand up. Once he stands up, if there's rapid filling from above, then it confirms the fault is at the SF junction. So the SF junction is incompetent. If there's no, if above no filling from above but rapid from below, then the fault is below the tourniquet. That means the deep perforators, either at the lower thigh or in the leg. And this test is repeated with the tourniquet placed at 3 sides, one above the knee and 2 below the knee. And this is known as the 3 tourniquet test, which can detect at which level is the deep perforators incompetent. Okay, now we come to the Perthes test. Now, Perthes test is also similar to the tourniquet test, where a tourniquet is applied at the upper end of the thigh. Now, the function of this Perthes test is to assess the functioning of the deep veins and the status of the deep veins, whether they are blocked or incompetent. Okay, so what you do with the patient supine, place the tourniquet around the upper thigh, ask the patient to ask the patient to raise their heel off the ground 10 times. That means ask him to exercise by raising the heel up and down for 10 times. Then look for the state of the superficial veins in the leg. If the superficial veins remain collapsed, as in this case, then it indicates the deep veins are functioning as the blood is returning back to the general circulation through the deep system. So the deep system is normal, patent. If, on the other hand, if the superficial veins fill up and gets dilated, okay, if even with the tourniquet on, if the veins becomes dilated, then it indicates the deep veins are if the superficial remains collapsed, the deep veins are normal. Okay. If the superficial fill up and get dilated here becomes more obvious, it suggests there may be a problem with the deep venous system. There may be a blockage or there can be incompetence. And the most common ones will be a DVT or an incompetent deep perforators. Now, there are some other minor tests that can be done. So this is a complete list. Trendelenburg, I've explained. Tourniquet test, the Perthes test, the Schwartz test, and also the Pratt's test, Morrison's cough impulse test, and the Fagan's test. Okay, these are the various tests that can be done on patients with varicose veins. So you go back and go through these tests and make yourself familiarized with these tests that are important. But as I said, the most important is the 3 tests: the Trendelenburg sign, but the tourniquet test, and the Perthes test. You must be familiar and able to demonstrate on the patient.
Okay, the first case is case number 1. The patient is Madam Lucy. She is a 62-year-old retired teacher from Merbok in Sungai Petani. She complains of a chronic ulcer over the lower aspect of her left leg for the past 6 months. Okay, and As a medical student, you are required to take a detailed history from Madam Lucy concerning the chronic ulcer over her leg. Okay, this is the picture taken of the patient's leg. Okay, now in this patient, you are required to examine the picture of the leg of the patient and describe your findings. Okay, the findings will be there's a chronic ulcer over the lower third of the leg, medial aspects above the medial malleolus, with surrounding hyperpigmentation and eczema. Question number 2. What examination will you conduct on the patient? The answer, I will do a Brody-Trendelenburg sign, elicit the Trendelenburg sign, tourniquet test, Perthes test, and Fagan's test. What is your diagnosis of this patient's condition? Chronic non-healing venous ulcer of the left leg. What investigations will you do for her? Ultrasound, especially the Doppler and duplex ultrasound, and if necessary, a venogram. Question 5. Outline the treatment of the for the patient. Initially, the patient will be treated conservatively with elevation of the leg, pressure stockings, and the use of medication deferral. If these do not help the patient, then surgical manipulations or surgical procedures will be taken. First, we have the non-invasive procedures such as the endovascular procedures, then surgical procedures such as eye ligation, avulsion, or stripping of these varicose veins. Okay, now we go a bit more into the venous ulcer. Okay, these are pictures showing you the venous ulcer. Okay, on the left here, this is a chronic ulcer, which is shown typically over the most common site of the leg, above the medial malleolus and the lower part of 1/3 of the leg. Okay, this is a superficial ulcer, and there's a lot of eczema changes with chronic hyperpigmentation and fibrosis of the surrounding tissue. This is the leg patients where the ulcer is healed and there is this chronic change here. This is your lipodermatofibrosis, which is due to chronic stasis of blood resulting in leakage of blood into the subcutaneous tissue and deposition of hemosiderin in the skin, which causes extensive darkening of the skin and fibrosis. Okay, this is a venous ulcer. Okay, typical site, irregular granulation, eczema. This is lipodermatosclerosis, blood leakage, and hemosiderosis. Okay, these are other pictures to show you the various types, grades of varicose veins which the patient presents. Okay, in short, the veins are elongated, tortuous, dilated, and palpable. Okay, here you can see belonging to the short saphenous vein over the posterior part of the leg, long saphenous vein over the lower part of the leg medial aspects. You see large veins, elongated, tortuous, dilated, and you can easily palpate them. Here, long saphenous vein, varicose veins involving the lower thigh. Okay, here he has a patient here with chronic ulceration, with lipodermatofibrosis, and a lot of eczema around it. Okay, this is a long saphenous vein over the leg. This is before treatment, and this is after treatment. Okay, these are gross varicose veins.
Okay, thank you for joining me. I hope this short session of mine would have helped to give you some guidance as to how to go about examining a patient with varicose veins. Thank you. See you again.